Thank you for allowing me to speak on a topic that I've spent the last 30 years studying. I would like to acknowledge and thank my fellow colleagues here with us today, and of course to DJO for sponsoring this event. I would also like to acknowledge my two institutions, Rush University, where I do research in the Department of Rheumatology, and St. Luke's Hospital, where I work in the Department of Physical Medicine and Rehabilitation. I am so fortunate and grateful to these academic centers that support me and allow me to continue my work. I often get asked the question, what is a bunion? The simple answer is a bunion is the inflamed prominence over the dorsal medial first metatarsal head. The more accurate medical description of the underlying cause is HAV, or Hallux Valgus deformity. What most people see as a problem is the alignment of the big toe in the medial foot that we call the Myers angle. The more accurate measurement can be obtained from x-rays, as the alignment of the big toe or hallux to the first metatarsal called the Hallux Valgus angle. A review of 78 studies with nearly 500,000 subjects shows the incidence ranges anywhere from 23% in the general population to upwards of 36% in older populations. This is also seen more in the female population, with females twice as likely to have bunions. Your first thought might be, of course it's seen in women. Have you seen the kind of shoes they wear? But research has shown it's not just shoes, that this pathology is much more complex than that. Quite often we see HAV occurring with other foot deformities, with most of them associated with foot instability and pes planus. What's interesting to note is that HAV was uncommon before we started wearing shoes. None of the Greek or Roman artists who were obsessed with anatomical detail showed a foot with a bunion. Even when we examine archaeological remains, there is not one foot with a Hallux Valgus deformity. It wasn't until much later that we started seeing bunions as a problem. So is it shoes then? I get told this by so many people that they have bunions because of the bad or poor fitting shoes that they wore as a child. But unfortunately, there is substantial research that seems to suggest shoes have very little to do with Hallux Valgus. So if not shoes, what else could it be? It's interesting to note that almost half of the cases appear by age 20 and what we often refer to as juvenile bunions. And it turns out that 54% of people with bunions report a family member with the same problem, suggesting this is an autosomal dominant trait. So what causes bunions? Like most pathology, it is multifactorial. The anatomy of the first metatarsal phalangeal joint is fairly complex, as is the biomechanics of the joint and the foot in general. The dynamics of gait, coupled with neuromuscular imbalance of the medial column, sets us up for the progression of bunion deformities. A few known factors associated with bunions are pes planus, or more specifically excessive pronation, medical conditions such as rheumatoid arthritis, neurological disorders, ligamentous laxity, or even anomalies such as amputation of the second toe or accessory bones within the foot. We also know that bunions are associated with larger Hallux valgus angles on anterior-posterior x-ray views of the foot, with the average being around 16 degrees. One look at this image illustrates for us that the first metatarsal phalangeal joint is a fairly complex anatomical joint. I'm not going to get into anatomical details, but it is fair to say that complexity makes this joint more prone for biomechanical imbalance and difficult to have just one surgical approach for repair. Because of the presence of the sesamoid bones, the joint is unique in that it has two joints but only one joint capsule. The more round the head of the metatarsal is, the more it behaves like a ball and socket joint. But what is most important to the stability of the joint is the condylar groove on the plantar aspect of the sesamoid's right end. If the groove is small or becomes eroded, the joint becomes more unstable. There is a thick intersesamoidal ligament called the plantar plate that keeps the two sesamoids together, and there is also a transverse intermetatarsal ligament that strongly holds the lateral sesamoid to the second metatarsal. What this all means is that the weakest attachment of the sesamoids is with the metatarsal head, so that if the head starts to drift as an HAV, the strong ligamentous connections will hold the sesamoids in place while the metatarsal head shifts medially, creating the deformity. This then essentially makes the tendon of the extensor hallucis longus function like a string on a bow, creating further neuromuscular imbalance to an already unstable joint. If you look at the muscles around the joint and create a free body diagram showing the vector pull of each muscle, you quickly see the majority of the muscles around the joint are pulling the hallux in a more lateral direction, with only the abductor hallucis muscle pulling medially to maintain medial to lateral stability. Research has shown that EMG activity of a pronated foot shows more activity of the adductor and flexor hallucis muscles, and that a foot with HAV malalignment shows a decrease in the abductor hallucis activity, and even atrophy of the muscle. When the deformity is bad enough, we even see spastic contractures of the adductors prior to purchase of the hallux, meaning the imbalance is occurring early in the gait cycle, before the hallux has a chance to stabilize on the ground. This is why we see bunions in neuromuscular disorders and why neuromuscular rehabilitation is so important. One thing to remember is that during dynamic gait, the goal is to push the body forward. So during propulsion, the trailing limb, the ground reaction force vector is pushing up against the ball of the foot with a force greater than the body weight. And this force vector is directed towards the center of mass of the body, that is creating an anterior and medial shearing force against the big toe and first metatarsal head, thereby promoting HAV if the medial column of the foot is not stable. Another thing to remember is that the axis of the first metatarsal phalangeal joint is not fixed, but is a movable axis, and in an open kinetic chain non-weight bearing configuration moves distal and dorsal as you dorsiflex the toe. However, because of the orientation of the ankle joint axis, the metatarsal angle in the axis of the first metatarsal phalangeal joint, the medial column of the foot has to plantar flex to keep the hallux and metatarsal head on the ground during propulsion. This means that as the ankle joint plantar flexes around 20 degrees during propulsion, the first metatarsal phalangeal joint must dorsiflex around 40 to 60 degrees. So, for the first metatarsal phalangeal joint to function properly in a closed kinetic chain situation, the axis of the first metatarsal phalangeal joint has to move proximally and dorsally, otherwise the hallux will compress against the metatarsal head, leading to joint damage. This, of course, is what we see when we have bunions with an unstable, poorly functioning medial column. I mentioned pronation and HAV are related. This is due to the inherent instability of the medial column of the foot with pronation. As the foot pronates, the arch drops, which changes the vector pull of the peroneus longus from a planar lateral to mostly lateral pull, allowing for the ground reaction force vector to dorsiflex the medial column during propulsion. This is why we see a decrease in pressure and load under the first metatarsal head in bunion deformities. And more importantly, this is why shoe and orthosis therapy is so important in treating bunions preoperatively and postoperatively. Unless you address the abnormal biomechanics, the deformity will get worse over time. Similarly, as the arch drops, the pitch of the first ray axis changes, so that instead of the normal dorsiflexion inversion adduction motion of the first ray, we get dorsiflexion eversion and abduction seen in a pronated foot, hence the abducted position of the hallux seen in HAV. So, depending on the orientation of the first ray axis, as the first metatarsal dorsiflexes, it will either invert and move towards the second, or evert and move away from the second. And similarly, as the first metatarsal plantar flexes, it will either evert and move towards the second, or invert and move away from the second. So, the take-home message is unless you have perfect biomechanical and neuromuscular function, dorsiflexion of the first metatarsal phalangeal joint, where the hallux is stable to the ground, will produce positional changes such that there is a relative abduction and valgus rotation of the proximal phalanx on the metatarsal. Certainly, positional devices and splints can alleviate symptoms if you can get your patients to wear them. Proper shoe therapy is always my first recommendations, since patients are open to buying new shoes. I always tell my patient that there are two things we need to address in our treatment. The first and most important is the underlying biomechanical and neuromuscular problem, and the other is the medical problem of associated pain and inflammation. Treatment for this can be anywhere from pills to injections, but most recently, we use mostly topical compounded medications, since a joint can be easily assessed by membrane-permeable biologics. I also utilize physical therapy and neuromuscular rehabilitation, which will be discussed later by my colleagues. Finally, as discussed earlier, you must address the underlying biomechanics with a functional foot orthosis, otherwise you are doomed for failure. Typically, when you're looking at footwear, you're looking for shoes that have the added stability to the outsole or upper, like a good athletic shoes. And occasionally you need stretchable materials across the forefoot for those patients with dorsal medial prominence that are irritated from poor fitting shoes, rubbing on the deformity. One thing to consider when doing conservative treatment for bunions is the need for a stable shoe that has the extra depth to accommodate any splinting and foot orthosis. I often tell my patients that when you come into my office and say, "I can't take this anymore," you are ready for surgery. The reason I hold off is that surgery has the potential for complications such as infection, chronic regional pain syndrome, and long-term problems like transfer lesions and stress fractures. But the one thing you have to consider is most bunion surgeries do not correct the related foot biomechanical and neuromuscular instability. After surgical realignment of the deformity, it is important to use bracing and support to reduce the likelihood of reoccurrence. This includes a splint for 1 to 3 months after surgery and shoe-foot orthosis combination probably for the rest of the patient's ambulatory life. You have to remember that I work in rheumatology and physical medicine and rehabilitation, so we focus on surgery when needed, but more importantly, what other modalities can help our patients. In this paper by Lisinski's group, they looked at 15 years of research and found 7 standout papers related to conservative management of HAV, such as exercise, manual therapy, bracing, and support. Their summary was that conservative therapies do not alter the alignment of the bone in the deformity, but they do decrease pain, increase joint function, and improve quality of life. And isn't this the ultimate objective to bunion treatment? We want to restore function of the joint and lessen the pain our patients are having. So my recommendations based on research and years of practice treating this pathology is splinting will work, and one of the best examples is the Acti-toe system. You need to control the underlying foot biomechanics, and the best way I found is with an orthotic that I can modify quickly while the patient is there and have them walk on it to give me an immediate feedback. What I like about the Exos is that it's a low temperature thermosetting material that I can even spot heat and incorporate small changes like a metatarsal raise. The most important and most overlooked area in the treatment is neuromuscular rehabilitation that my colleagues will speak on later. And finally, shoe therapy that includes stability but also has the extra room in the shoe for the required bracing and support. Thank you for allowing me to speak with you today, and if you have any questions, please feel free to email me at these email addresses here.
Good evening, ladies and gentlemen. Thank you for taking time off your busy schedule to join us for this series of webinars. I would like to thank the organizers for inviting me to give a talk on surgical management of Hallux Valgus. Hallux Valgus by definition means lateral deviation of the big toe. In layman's terms, it's called a bunion, which is a Greek word for turnip. Over here you can see a famous movie actress from Malaysia and her equally famous head honcho from Formula 1, where you can see she's got a deformity which is characterized by lateral deviation of the big toe. over here and a medial deviation of the first metatarsal with subluxation or dislocation of the first MTP joint. It's common in the shoe-wearing population, only occasional in the barefoot population. In LUM study, 1/3 actually wore shoes most of the time versus only 2% which hardly wore shoes, and those 2% of bunions are usually asymptomatic, ladies more than men, and almost a 70% familial tendency. So if your mother or your sister has it, chances are you have it too. Etiology is related to shoe wear mainly, where ladies' high heels have a narrow constricting toe box, like so. Or these are other examples of similarly tight shoes. I don't know why they use something like a horseshoe here. Other etiologies are things like a metatarsus primus varus. As you can see, it's the first ray is in varus. And if you have a flat foot or pes planus, the hallux valgus will progress more and more rapidly. You can get a hindfoot valgus and pronation as well, and usually it's associated with a tight Achilles tendon. With the tight Achilles tendon, pressure over the forefoot is increased and giving rise to bunion pain and more progression of the bunion. So over here, another etiology is generalized joint laxity like Ehlers-Danlos or Marfan syndrome, where normally our weight is on the big toe, the little toe, and the heel, forming a triangle. But when your big toe is incompetent, it doesn't bear the weight. So this is a hypermobile joint. Anything more than 9 millimeters, I can make it in a frown and a smile even. So the weight is then transferred to the second toe. You get it also in neuromuscular conditions, like this patient has got cerebral palsy. Sometimes you get it in stroke, trauma, inflammatory like gout here. Rarely I see it in congenital in babies. If you have loss of a second toe from amputation from a diabetic wound ulcer, you can get hallux valgus. In this patient, the second and third toe are short, so there's a loss of a post there. The shape of your head of metatarsal also plays a part. If it's rounded versus a chevron, more stable versus a flat metatarsal head. Your metatarsal cuneiform joint, if it's horizontal, unlikely you'll get a bunion versus a oblique joint. There are 4 muscle groups around the first metatarsal phalangeal joint, and usually what happens then will be when you get a hallux valgus, you get an unbalanced muscle pull leading to a progressive deformity where the sesamoids will sublux and the great toe will pronate, and this needs correcting. Here you can see the abductor hallucis, the adductor hallucis, flexor hallucis brevis, and on the dorsum, the extensor hallucis longus, extensor hallucis brevis. There are no muscle insertions in the first metatarsal head, so it sits in a sesamoid sling. So what happens then when you have a lateral deviation of the proximal phalanx? You get a medial deviation of the metatarsal, attenuation of the medial capsule, and contracture of the lateral joint capsule. So this sling is held in place via lateral attachments. The head moves medially. When that happens, the abductor hallucis rotates plantar and then the toe pronates, and the sesamoid will rotate into the web space. And this is an axial diagram of how that happens, where the sesamoids go into the web space and this thing gets contracted. So then there will be incompetent weight bearing under the first metatarsal head, and then transfer metatarsalgia, where the weight is transferred to the lesser metatarsals, like here you can see. And what happens then, you get callosities, you can get stress fractures, you can get synovitis leading to capsulitis, and that can lead to a plantar plate tear, and then you get loss of stability of the second MTP joint, which then leads to clawing and then frank dislocation as in a crossover toe. So in history, you need to know what the patient's hobbies are, you need to examine them properly, examine their shoes, do some x-rays, and know the patient's personality and expectations. Pain is usually what brings them to see you, up to 70%. 80% will have difficulty with all sorts of shoe wear. A lesser amount will be because of the bump and because of cosmesis. There can be bursal inflammation, rarely ulceration. You get pain over the plantar aspect, over callosity. You may get flat feet pain, and then second toe pain, which is the transfer metatarsal occurs in about 40%. So you need to stand and sit patient, look for the great toe pronation, look for flat feet, check for TA tightness, the gastrosoleus complex, do a silver scrote test, check for hypermobility like I showed you earlier, and then look for callosities over the second toe as well. Investigations are the mainstay are x-rays. You can do an AP, oblique, true lateral, and then here you see an axial view where the weight is on the medial sesamoid or tibial sesamoid. You can measure angles like the Hallux Valgus angle, the intermetatarsal angle, the distal metatarsal articular angle. Later I'll show you how these angles are measured. But usually I don't normally measure them unless I'm doing some form of research. Lately, the in thing is doing a standing CT, and hopefully by this year we'll get our first standing CT in Malaysia. So look for arthritis in the first metatarsal joint, whether it's congruent, whether the sesamoids are sublux, and look at the hind foot for flat feet or high arch feet. Always remember to get weight-bearing x-rays. As you can see, non-weight bearing a mild bunion, weight bearing a severe bunion. And these are the angles, the Hallux Valgus angle, the intermetatarsal angle, the DMAA here, okay? And you can use that to stage whether it's mild, moderate, or severe. Usually, I will just eyeball it and I'll know whether it's moderate, severe, and whether it's scuffable, which relates to the main surgical intervention that I do. So I won't dwell on non-operative treatment, which mainly for the elderly and unfit for surgery. So when pain is inadequately controlled, you need to do surgery. Beware of the cosmetic patient. I always tell them if you substitute a bump for a scar, the scar can be painful. So you have to manage your expectations. You may not always get 100% result, and only 60% can wear unlimited shoes post-operatively. The education is important. It's not as easy as this advertisement here. Try to avoid surgery in athletes or dancers, and for those who go for cosmesis. I had to do surgery in a ballet dancer once because she also had osteochondral defect there. So the aim is to get a biomechanically functional foot. As one of my mentors used to say, make the foot look like a foot. And so you have a variety of surgical techniques, and these techniques will depend on the prominence, the angles, the pronation, and whether the sesamoids are subluxed. Whether the joint is congruent or incongruent. Congruent is usually less prone to progress. Check the degree of deformity, whether there's arthritis in a juvenile patient, whether the physes are open, and whether there's hypermobility. More than 130 operations have been described for bunions. No single procedure is perfect, and therefore you need to be familiar with several. Complications do occur. The main, by far most common issue will be of joint stiffness. If you can get about 80% of your range of motion prior to surgery, then that is very good already. So the technique has to be reproducible, stable, try to maintain length, correct all the angles, preserve the blood supply, and have a low recurrence rate. Over here you see the windswept toes obviously will be more difficult than this side. So the first procedure I'll talk about is a chevron osteotomy, which is a V-shaped osteotomy meant for mild to moderate bunions, but there's a risk of AVN which can go up to 20%. You start with the lateral release here, which is a dorsal intermetatarsal incision. Release the suspensory ligament, open up the capsule, and then release the sesamoids. When you release the sesamoids, you mobilize them and release the contracted lateral structures until you can deviate the toe medially. And then you do a medial incision to excise the medial eminence, like so. If it's a very mild bunion, you can also do a lateral capsule release through the medial wound, either plantally or dorsally. But you should have a bovie blade like this, which we don't have, so I rarely do this technique. After you shave off the bump, mark the apex as the center, angle a guide wire about 20 degrees plantally, and it has to be perpendicular to the second metatarsal. Do a short dorsal cut and a long plantar cut. Complete the cut with the osteotome. You may need to free the dorsal capsule here, translate it laterally, impact it and hold with K-wires. You can fix it with a cannulated screw from the dorsum, or if you're coming from the bottom, you can use a biopin, and don't forget to shave the prominence after you're done. This is an example of a chevron osteotomy. She also has a pre-existing flat foot, so I use a arthroderesis screw to raise her arch. So by far the most common osteotomy that I use will be a scarf osteotomy, and this is very popular in Europe and in Australia. It comes from the carpentry origin, where you do a Z-shaped step cut. It's very effective and versatile, and the corrective power is higher if you combine it with a varus osteotomy of the proximal phalanx, which is an Akins. But you must always do the distal soft tissue procedure. So these are the cuts, again perpendicular. You make a Z cut here, which with an angle of 60 degrees, shift the bone down and inwardly and sits on the relocated sesamoids. Always try to maintain the transverse arch. More severe hallux valgus, you can use a scarf to treat them, but you need to shorten it a bit, which is doing this maestro cut here. And if you have a pronated big toe, have a low threshold to do an Akin osteotomy, my Singapore mentor always said, if you think about it, you should probably do it. It's very important to maintain the parabola of the lesser toes. So if the second and third toe are very much longer, you need to shorten it to avoid metatarsalgia. And usually I will use a real osteotomy to shorten, which is a horizontal cut like this, shift it in, and then remove the osteophyte. Other techniques, this method is very popular in North America, which is a Lapidus, which is a TMTJ fusion here. You have to combine it with the distal soft tissue procedure. It's very, very good for hypermobile patients. And if there's osteoarthritis of these joints, very severe deformities can be corrected. The only downside is that there's a prolonged period of recovery because you have to wait for the joints to fuse. However, satisfaction rate can be very high, up to 90%. In rheumatoid patients or very badly arthritic patients or revision surgery, recurrent deformity, neuromuscular disease, very elderly. As a salvage procedure, you can do a first MTPJ fusion like here, and also very good success rate, but however you lose a little bit of mobility and walking speed. Other adjunct procedures, if the patient has an associated flat foot, you can think about correcting the flat foot. If they have a valgus knee, also you need to correct that. Especially important, you need to look for the gastroc tightness, where you need to do an Achilles lengthening or gastroc release. This is a patient with Hallux valgus, pes planus, and an equinus contracture, very tight Achilles. So here you can see I corrected the bunion, the right foot, with a lapidus, a wale here, and here you can see a lateral column lengthening for the flat foot. Post-operatively, for scarf osteotomy, I always put them on these auto weight shoes, which are offloader shoes, where the weight is over the heel and not over the toes. They usually wear them for about a month before they can progress to normal shoes. Complications, I'll just run through real quick. You can get undercorrection like here. You can get avascular necrosis in chevron usually. You can get a neck fracture like here where I have to put an extra screw to fix it. And sometimes you can overcorrect. This patient was corrected nicely in the OR. However, many years later, she came back with a Hallux varus. You can also get a non-union. This patient of mine had a union of the navicular cuneiform joint, but a non-union of the first TMT joint. You can get implant problems. There's usually some push by the implant companies, like using a tightrope here, which I don't advise because then the button can sink into the soft bone here. In the old days, they used to do a lot of Mitchell's osteotomy. You can get a dorsiflexion malunion, and then you get a transfer metatarsalgia to your lesser toes. You can get sensitive scars, some neuromas, even CRPS, a complex regional pain syndrome, infection, osteomyelitis, stress fractures, and remember I mentioned earlier, stiffness is the main issue. Here you see two bunions that have been corrected before and there's some recurrence. So my algorithm, if it's very mild, I usually do a chevron. If it's moderate to severe, I do a scarf. If there's a lot of hypermobility, I do a lapidus. And if there's arthritis, then I fuse the MTP joint. If there is a hallux interphalangeus or a pronated big toe, then I combine it with an Akins. If there's lesser toe metatarsalgia, then I'll do a wale osteotomy to maintain the parabola. This is an example, everything in, okay, dislocated sublux bunion, dislocated second and third toe, claw toe, and this immediately after surgery, scarf, Akin, double wale, and a Duvries arthroplasty. And after 6 months, everything looks good, and everything is fused nicely, and then that's the time to do the other side. So the other side, here you can see step by step, doing a scarf osteotomy, sliding it in, a wale osteotomy, an Akin osteotomy, and this is what it looks like after everything is done. Okay. So the take-home message is that scarf osteotomy works together with the distal soft tissue release. A severe hallux valgus needs a shortening scarf. You need to maintain the parabola with shortening of the lesser metatarsals. If there's a tight Achilles, it needs to be addressed. Other alignment issues should be tackled as well. Thank you, and probably we'll take some questions later.